so let's get started. So this is, as I mentioned, it's from my perspective because I haven't received really anyone's perspectives yet. So as I read your report, and I mentioned to you last week, we go through the good, the bad and the ugly together because my goal is to help you get the most out of ePPOC for both your patients and yourself and your service. So let's get started. As always, I like to acknowledge the traditional owners of this land, the Aboriginal and Torres Strait Islander people, and in particular, the land I'm on belongs to the Wadi people of the Dharawal Nation. So I want to pay my respects to the elders, past, present, emerging, and future. So the really good news is that when you first glance at your report, you would have seen that you met 5 out of the 9 benchmarks. So you met average pain, depression, anxiety, catastrophizing, and self-efficacy, which is great news. And you just scraped in under for pain interference. So that's great news. There is, however, with that, because if you looked at the numbers for those benchmarks, you would see that they were very low. So the number of outcomes were like, for example, 9 or 10, or 11. So they're very low numbers. So when you're thinking about analysing data, there's often this magic number of 30 as being, okay, you need to get to 30 outcomes to be able to really look at the data in a more robust way. 50 is even better, 100 is even better. So we often set the goal of getting to 30 outcomes before you start to look really solidly at the clinically significant improvement and the benchmarking outcomes. So it's a good start. You're on the starting blocks, and let's call that your PB, and we'll move from there, hopefully. But before we begin, I just want to say, when it comes to data analysis, I love this meme for a data nerd like myself. Remember that we are looking at numbers basically in your report. There's a lot of numbers, and what I've said to Carlos before, there's only a problem if you look at a number in your report and you can't explain it. So if you can see, oh, okay, we got this result, and you think to yourself, all right, but that's because of X, Y, and Z. If you can explain it, then it's not a problem because it can be fixed. But if you see a number in your report that you can't explain or why you're there, then it becomes a problem. So that's something where that's often a sign that's a place you might want to begin to work with. So it's all very well for me because I've got a deck of cards in front of me that I can line up beautifully, and they stay that way. I could put them on my desk and they wouldn't change. The view for you guys probably looks more like this. So it's all very well for me to sort of say all these, you should do this and I think you should do this, but I'm very cognizant that it's got to all be possible in the context of the challenges you face on a day-to-day basis. So that's where I'm coming from. And I know, Brigitte, you said last week you really wanted to use the report to get some benefits for the service. And so to gather the data that you need to, 1, demonstrate the hard work you are doing, demonstrate positive change in your patients from that hard work that you do, to gather the data that you need to identify for areas for quality improvement in your patient care, and more importantly, well, not more importantly, but importantly, to possibly identify areas where you could advocate for funding or staff or facilities or resources. I'm afraid you're going to have to go back to the basics. And that might not be, like, you've been doing ePPOC for a long time, but I think after looking at your report and spending a lot of time looking at previous reports, there's a lot of just basic, really simple interventions you can do to really get the ball rolling. So that's the good news. So from my analysis of this report and your previous reports, I've had a really good look. I have 8 things that I'm just throwing out to you. And of course, I don't know, as I've mentioned, whether they will work, but this presentation will cover these 8 things. Producing a service delivery map. We've already got that ball rolling. Carlos has sent me some maps, and you're going to send me a few more things that'll give me an understanding of how your service works, and I'll embed ePPOC into it. We need to get started on operation outcomes because, if I'm honest, your outcomes are very low for all the hard work that you do. The outcomes within your report, I should say. So we're going to work on aim for equal and score the 4. They're simple initiatives, and you'll see in a minute. We need to increase your office use only completion, the section in which is important patient medication data. There's another, you guys need to have a meeting as a team to try and work out what is the signal for an end of an episode for a patient. And we'll talk about that. We're going to look at patient requests for questionnaires that are outside of the 4 you need for ePPOC, to avoid what I like to call questionnaire fatigue, which I see a lot in patients, because if any of you have ever sat down to fill out a questionnaire, you'll see how long it takes and how arduous they can be. We're going to have a look at establishing patient expectations and ways that other services have done that, which has indeed increased their outcomes. Reviewing the service event entry, and finally having a look at the use of the concurrent pathway. So let's get cracking. All right, I'm not going to spend too much time on this, but over on the right, you won't be able to read it, but it's just an example of an algorithm where you can see the patient comes in at referral and they move through the various sections. But on this side, you'll see is ePPOC has been embedded in the 4 opportunities. And so it's important that once we do make a service delivery map, that it is a team meeting is held, it is generated and spread out to the team, it's printed out, it's put up on computers, beside computers, etc. It's talked about in team meetings so that everyone's aware, everyone's on board at these important time points in a patient's care. The next is to your mission, should you choose to accept it, is operation outcome. And that involves 2 simple initiatives down the bottom here. It involves a commitment to aiming for equal and score the 4. And let's talk about them now. So aim for equal. It's dead easy, but it's dead easy for me to say it, but it's another thing to be initiated in a service. And one of those things that will help with this is completing that service delivery map that I've talked about. So aim for equal is simply trying to aim for the same number of referred patients who go on to treatment. Obviously, you have some people drop out and they don't go on, or their treatment's not suitable for them, etc. If they go on to treatment, they need to be entered in both an episode and a pathway. This is really important because those are essential elements to set up getting all 4 possible outcomes, and I'll explain how. So here's your aim for equal. This is I've gone back through all of your reports, right back to 2015. So here's a really beautiful, I couldn't have asked for a better representation of how aim for equal works. So what you see is the red line is numbers of active patients. The purple line is the number of episodes started. So you can see that for a while, and ignoring the start because this is when you first started, for a while they were quite close. Then you got on board with pathways, which is the weird green colour. And you can see as your pathways are closer to the same number as active patients and episode starters, the outcomes match it. Do you see that? But it's when you start moving away. So something happened in 2018. So this is your 2018 annual report where you've got the lowest number of outcomes you've had. Now, I don't know what happened because I wasn't looking after your service at that time, but you can see here, you've started a lot of active patients, but they have not been entered into episodes or pathways. So therefore, outcomes follow. And this has been an ongoing trend for 2018. So it's clear you've got active patients and you're doing all the hard work, but it's not being represented because they're not being entered into both an episode and a pathway. So that's a really simple way to demonstrate it. The other thing you can see that in is in your flow chart in your report at the very start. It's figure 2 in your report. So that's aim for equal. Score the 4 is just talking about you have 4 opportunities to assess your patient's condition and or progress. And it involves 4 questionnaires that eventually turn into your patient reported outcomes, and they help you with quality improvement and your reports. They generate your reports effectively. So Score the 4 has important bookends. And so the first important bookend, the alpha, if you like, is the referral questionnaire. That's probably the most important questionnaire, especially for you guys. It gives you triage information, but it also gives you a snapshot of what your average patient looks like. It tells you how your patient's doing when they arrive and what care they might need. So that's really important. The other important questionnaire sounds strange, but it's the pathway end questionnaire. So you can already see that if you have a referral patient, that's great, and you get the referral questionnaire. If you haven't started them in a pathway, you'll never get a pathway end questionnaire. So this is why you're missing out on outcomes. So every patient that comes in for a referral that is started in treatment must be entered in an episode and a pathway. It's really important. Often you don't need the pathway start questionnaire. So this is a good way to avoid questionnaire fatigue that I mentioned before, because patients, it's your decision, but if the pathway is started, and I note in your reports, most of your pathways or your treatment is started within about 96 days. So that's less than 6 months. So if a pathway is started within 6 months of referral, our program uses the referral questionnaire data as a proxy for the pathway start. So that's one less questionnaire that the patient needs to fill out. It's your choice though. If they do come in when it's treatment start time and you think, oh, Mary's looking a bit worse since I've seen her, or you want to get that pathway start, it's always a choice. But if you want to avoid too many questionnaires and you feel there hasn't been much change since referral in that 3 months when they start a pathway with you, then absolutely click never create for that questionnaire in epicentre. For those of you who are, give me a nod if you're really familiar with epicentre. Yes, that is, okay. I get 2 solid nods. Okay, so you'll know what I'm talking about and you can educate your peers. So the pathway end is the really important bookend. That gives you your episode outcome, but you must end the episode to get that outcome. Does that make sense when I say that?
When you end an episode and put a questionnaire with the end of episode, does that mean that doesn't count as an outcome?
So any questionnaire that is outside of the ones that automatically generate at certain times in epicentre. So if you enter a patient at referral, a questionnaire will pop up and say, do you want to send this one? So that's what we call one of the 4, the Score the 4 that pop up automatically generated in epicentre. If you are generating ad hoc questionnaires, they are not guaranteed to be used as an outcome. So it's really important within epicentre, to use those moments when they pop up to use that questionnaire. And in epicentre, you'll see, if I can show you, is that big enough? Can you see that? Yep. So, for example, if I'm in questionnaires, and actually I want to create a questionnaire for a patient. If I want to add a questionnaire, so up here, if I click on add a questionnaire, there'll be a drop down in the menu. And if it just says clinical review, So that is what we call, for example, an ad hoc questionnaire. When you add a questionnaire, it should only really be done if you want a clinical snapshot of your patient. For example, you notice Mary's come in for an appointment, you haven't seen her for a little while, and she's looking really not good. And you think, you know what, Mary, would you mind doing a questionnaire, because I just want to see where you're at and see what help you might need. So ad hocs are important for a clinical snapshot in time, but they're not necessarily used by the program as outcomes. So you've got to be careful when you generate ad hocs. So most of the time you should be, I've got to find a patient who needs a pathway ended. This is a fake database, by the way, so there's nothing real. Oh, okay, here we go.
Okay.
So this is Maggie May. So she's a patient, she's had a few pathways, she's ready to end. So if I click end now, I've got to put a date, obviously. Now you get this checkbox that says, is this also the end of an episode? And if it wasn't, I'd just leave that blank and I can click submit and a questionnaire will pop up. But let's say I want to end the episode as well, because I'm trying to get you guys to end episodes. Let's say the treatment is complete. If I click submit now, an automatic, so this is an outcome opportunity because it's being created by the program in epicentre. So this is one that I definitely want to create now for this patient. Otherwise I'll miss out on my episode outcome if I don't get it. So try to think about that. And I've noticed in some of your ad hocs, for example, you always put a description, which is wonderful for us. That's really important. And thank you. That's a really good initiative you already have going. But I've noticed there's about 14 or 15 that possibly could have been episode outcomes because it says end, program end or something like that. So it's important to always try and use the pop-ups because they're going to be outcome measures in epicentre, if that makes sense.
I would say that I think that we're better at ending episodes than we used to be. It's just that we don't get the questionnaire results. Yeah,
and the other thing to do as well is we'll come to it when we chat about ending episodes, that section. But I can say it now that when you do have that team conversation about trying to think about formalising what signifies the end of an episode, as clinicians, you might be able to start getting them to complete the pathway end questionnaire on or near their final appointment in clinic. So I don't know if you have those facilities like a laptop or a tablet or a iPad, some sort of device. And that's the way other services who get really good numbers for outcomes get their final questionnaire done. So that's why it's good if you discuss as a team, what is the end of an episode? Is it when we start tapering appointments? Okay, if it's that case, then the next time Mary comes in, I'm going to get her to complete a pathway end questionnaire and we'll end her episode. And look, it doesn't matter if she comes back the next week having a big flare up and she needs to be seen again. You just start a new episode because her data's already there. Her information's already there.
It's good that you said that, Janelle, because usually what happens is that we, from an operational sort of point of view, I'm looking at active lists and, this person hasn't been engaged with us for this period of time. Let's discharge them. That's kind of the main reason why we discharge. And then we close the ePPOC episode, but it's probably one because we don't have their email address within there. Maybe another step, or we probably think that the patient isn't going to actually, if we send them the ePPOC, like the ePPOC link, then they probably won't do it because they've never engaged throughout their whole service. So that's what I'm seeing a lot right now. But it's probably because we've got to do a lot of discharging and cleaning up our active list anyway. So
this will all unfold later. We'll have, obviously, this isn't our last conversation. We'll work together. So moving on, top tips for Score the 4, and we go through a few of these later on. So this means getting all of the questionnaires completed. Setting up expectations early for patients in a welcome letter, and I'll show you an example a little bit later. These are examples from services I've worked with that have really improved their outcomes. Embedding the 4 opportunities in the delivery map, we're going to start doing that. Where possible, have patients complete questionnaires in clinic. So the referral questionnaires not too bad. They tend to do that because it's all exciting and new, but they drift off, and the remainder, it's much better if you can have other devices to complete them in clinic. And it's very easy to do. You just scan the QR code, and people are very savvy with QR codes. That's one thing we can thank COVID for. The other thing is to make sure you demonstrate the value of their completed questionnaires by printing off those patient reports, 14-page ones, and going through it with them, and they really see the value of what they're actually doing, and that there is an outcome to what they do, and they don't just drift off into the database. Decide when to end episodes and do it. Have patients complete them in clinic, as I said, and most of the time, if you can predict kind of when an end of an episode is coming, then you can get them to complete that pathway end one, which is a really important bookend at the clinic, close to. It doesn't have to be, after they've completed, it can be near. Arrange a post-episode follow-up appointment. This is services who've gotten really good outcomes for post-episode, usually have them back in for a very brief appointment. So for example, it goes something like this. They come in, if you have an admin person, the admin person generates the code for the post-episode follow-up questionnaire, gets the patient to complete it, and then prints off immediately the report, gives it to the clinician, and the clinician only has about a 15-minute consult where they say, hi, how you doing, and work out if there's any need for further treatment. And the other thing is to limit unnecessary questionnaire requests, of course, unless you need them for clinical review. All right, so you can assess both aim for equal and score the 4 in your figure 2 of your report, probably on the second page or something like that. But this is a flow chart of what's going through your clinic as far as questionnaires go. So aim for equal, you can see you guys started with 201 referral questionnaires. You started 162 episodes. I think that's fantastic, amazing. And then the ball drops with the pathways. So you can see now, hopefully, that if you don't start, if this number here, that's 38, is not around 160 or 150, you're missing out. You cannot get a pathway end questionnaire because they're not in a pathway. And the pathway end questionnaire gives you the episode outcome. Are you still with me?
Janelle, I'm just, so why is it, so what happens, like, because what we do is, so when they enter into SOS or a straight to medical, we send them like an ePPOC link via their email. So does that equal the 162? So 162 people have opened their email and have completed, is that what 162 means?
The 201 is the referral questionnaire. So that is the very first one. When you enter them into your system, Up will generate automatically, epicentre will generate the referral questionnaire, and that is the one that you've sent to them. So in 2020, so patients referred in 2020 was 121, and then there were 80 from a previous period. But because they had this flow chart's quite complex and would involve another length of time, but I'm just trying to teach you that this number here, these you should be close to this number.
Yeah.
So your 162 episodes started, it'd be nice to see around 150 pathways started if those patients indeed go on to treatment. And that sets you up for getting all 4 ePPOC opportunities for Score the 4. So that's
probably the newest like kid on the block with regards to experience with epicentre. So what is it that we're not doing from like 200 and 201 to 162, and then obviously 162 to 38? Like what is it that we're not doing? Like,
I can see a hand up. Alison's got a hand up. Go, Alison.
Yeah. I just wanted to let you know, because I think I know the answer, but I don't know if it's right, and maybe Eddie can help me make sure I'm right. But so we have to manually start the episodes, Carlos. So, you know, when someone comes to SOS and they fill in a questionnaire, then we have to do the next level, which is press the button that says start the episode. And so we've been way better at that than we ever were. And that's why our numbers on that first line on that graph were really high, because we made a commitment to bring a laptop to case conference. This is before your time, Colour. So we never used to start episodes. And so then we make sure in case conference, that's one of the ePPOC person's job at case conference, is to make sure the episodes are started and, you know, pathways are started and so forth as well. But I think what's happening is that we start the pathways, but we don't generate a questionnaire. And that's where we're getting a loss of outcome.
Well, that's, so you're kind of on the mark. So this number that we get, 38, shows us that you physically started down here a treatment pathway. So when someone comes in, so who have we got here? Bonnie Brown, if you can see that. Oh, I've got another hand up. Go, Eddie.
I sort of want to share my screen, but it will have client details on it. Is that an issue, Carlos?
It's a bit of an issue. Can you explain it to Janelle via here, if possible?
So
you can screenshot and block it out later, and we can chat later, Eddie, if you want.
Because what I've done is I've just gone into ePPOC. I've filtered it by referral date. So I've got some of our newest people. Yeah. So the first one, referral date 19th of April.
Yeah.
His referral date was the 19th of April. His start date was the 19th of April as well.
Yeah.
And the treatment pathway hasn't been started yet. Then I go to the next one down is the referral date was the 14th of April, but there's no start date, and I don't know why.
Okay, so just a few things in our sort of protocol of understanding, and it's in the clinical reference guide, and you may or may not have seen that for a very long time, but we do have a data dictionary, a clinical reference guide that explains what each of these elements mean. So this is when you've got this screen, this means Bonnie Brown's come into the clinic and she's just said, hi, I've got a referral. So I'm going to say, all right, Bonnie, I'm going to enter your details in, and I've got a referral date. So I'll go today, and no, it's not for cancer pain. Let's say she came from her GP. And if I click submit, I'm going to get my first automatically generated questionnaire. So this is, as you can see, episode referral questionnaire at the top. So definitely I want that, okay? I'm not going to do that because we're in the middle of a presentation. All right, so that's okay. So let's effectively say that Bonnie's now I've sent it off via email. That's the link. You've sent someone via email. But there is often a little bit of time before the episode will start, because an episode starts at the first clinical contact with a patient. So it's not just that they come in and someone from admin shows them where the exits are and the toilets and what they're going to do. It's when they see a clinician or anyone have clinical contact, might be an education session, etc. Might be an assessment, MDT assessment. That is when you click on the start button. And this indeed is what calculates, oops, I didn't select a mode. That's what calculates the wait time. You know how you get wait time reported?
Yeah.
Well, it's from referral date to the start of an episode of care. So now, let's say Bonnie Brown's in an episode of care. She started, but you've still got to maybe do an MDT assessment. You might want to take them through an education program. That's fine. They're all things that can be added into service events. But let's say after a couple of assessments, you go, all right, I'm ready to work out what sort of pathway this is suitable for Bonnie. And so this is the important step that's missing. So you click pathway start. Again, let's say it's today. It's obviously not, but let's say it's within 6 months of the referral questionnaire. All right, so I'm going to book you. You guys often choose concurrent pathways. I'm going to click submit. So create a pathway start questionnaire. Now, as I mentioned, this is one of the score the 4. So it pops up. These are the important ones to deal with properly. Because it's within 6 months of referral, I'm not going to make my patient do another questionnaire because it was only a few weeks ago, for example. Let's say it was 6 weeks. Only 6 weeks ago, they did a referral questionnaire. I don't need to know how they're going. So for this one, I can click never create. Once I do that, our program uses the referral as a proxy for pathway start. So it still says you've got a pathway start questionnaire. So this is the important thing for Aim for Equal, just making sure that everyone's entered into a pathway and something has been done with the pathway start questionnaire, whether they do it or whether you say never create if it's within 6 months. Those are the important steps. And then the final important step is the pathway end, which gives you that bookend, which will give you your episode outcome if, as I said, you end the episode. Does that?
So the number 38 on the far left there on your PowerPoint slide, that is the treatment pathway start?
Yeah.
Is that right?
Yeah, you can see, well, if you open your report, this is from your report, you won't be able to probably read that. But so this says pathways started, 38. So if this said around 150, it doesn't guarantee an outcome, but it sets you up to get those outcomes. Because if you haven't started the pathway, the patient can't complete a pathway end questionnaire. So Aim for Equal is about setting you up to get all 4, to score the 4.
Yep.
I don't want to dwell. I'll send you this. Anyway, Alison, go.
I think I'm following you and thank you. You're doing a great job of explaining, but I have one question that if we're scoring the 4, then, and I understand that it's the ePPOC epicentre will use the referral questionnaire as a proxy if the pathway start is within the 6-month window of the referral questionnaire, which is pretty much 90% of our population. So that happens all the time. So that's really good. But then we have to get pathway end, you said, but that's only 2 then. We've got referral, pathway end, and I'm wondering where the other one is. And
okay, so I'm still counting. So you've got referral, pathway start, even though it's done as a proxy, that's number 2, because you've dealt with it in epicentre, if that makes sense. So it's important when you get that pop-up that you either get it, like send it to the patient if you want it, or go, okay, no, say never create, and it's used as a proxy, but it's still number 2. It's still number 2. Number 3 then is the pathway end. And this is the one that you'll get a lot more outcomes if you get it sort of close or near their final appointment. But that involves you guys having a chat about what is the end of an episode. So that's the other important one. And then as I said, if it is the end of an episode, tick that box as well. And that way, when they complete it, you've got an outcome. You've got a treatment outcome. It's as simple as that, really. So that's number 3. And number 4, of course, is I'll close that, is the post-episode follow-up, which will be listed here. Yep.
Okay, so apologies if this is a redundant question, but we can get away with referral questionnaire, possibly miss the pathway start if it's within 6 months. We get ourselves a pathway end questionnaire, and then it's almost like and then that would give us an outcome that would up our number of 38s. It would, our number is 38 this time, but we would get more if we did more of those. And then the icing on the cake is the post episode number 4. Is that right?
Yeah, but look, to be honest, and we've got a lot of longitudinal data now, there seems to be, we're actually looking quite in depth at post-episode. Obviously, we, at the start of ePPOC, we said, well, actually clinicians, we didn't make this up, you guys, the clinicians decided, they want a post-episode to measure treatment maintenance and longevity, etc. But what we're finding in the results after all these years is that there's very little change for most people at all. Their results are, and you'll see that in past reports, if you go back and have a look, there's very little change at the post-episode time frame. It is difficult to get that questionnaire. It's got the lowest response rate traditionally because patients are often done and they don't want to do any more questionnaires. So that's complex, but the 38 is you entering everyone into a pathway. So that's the other one. The number 3 is getting that questionnaire at the end of the pathway, but you'll never get a generated questionnaire at the end of the pathway unless you've entered them in a pathway in the first place, hence dealing with this. Yeah. I'm happy to chat at length later on.
No, I think I understand better. And you said at the beginning that, the golden number is 30, as in, data only starts to mean something once you get 30 as a minimum, and we got 19, so that was pretty rubbish. And so obviously, it'd be nice to get 150. So I think I'm with you now. Thanks.
Awesome. I'm happy to chat to anyone at any time later on as well. I love it. This is my bread and butter. I weirdly enjoy this stuff. So
Janelle, I'm just a little bit confused because I've got referrals 1 point, episode start, then the pathway start is the second point, pathway end, third part. When do you do episode end?
Episode end is, well, I'll get epicentre up.
With treatment pathway end.
Yeah, so when you've finished a pathway of care.
Yeah, then you do episode end?
Yeah, you end pathway there, and then you'll see there's an extra check box. It says, please tick this box if it's also the end of a pathway. However, you can also end a pathway having it not be the
episode end.
That's
at end. I can go submit. This is still an important generated ePPOC questionnaire. It'll make more sense when I embed it. Trust me, it'll make more sense. So here you will get this. All I'm saying is it's always important to get the pathway end questionnaire. It's so important.
Yeah.
And I can do that now and get that questionnaire, and it's all very well. But if I don't end the episode, I can't get an episode outcome on your reports, because according to us, the patient's still in your care. The episode of care has not finished. So you can't get an episode outcome until an episode of care has ended.
Yeah.
Does that make sense?
Janelle, so do I understand if we did the end of episode, that generates a questionnaire, and if we help the client to fill that in, that is also going to be used for this is how well or how not well you did in doing your treatment here. Is that questionnaire which also actually gives you the outcome measures? Yes. Yeah. So you would have that conversation with the patient anyway, wouldn't you? So once we actually do the mapping, as you're asking us to do, which would be really good then for us to sit down to see at what point are we going to do the discharge, the end of episode. Or in the pathway, because that questionnaire will be used as our outcome measures and the conversation with the client about where to from here, which sounds wonderful. That way you don't actually miss it. You don't lose it because you have to use it and you have to get them to do it so you can actually end there.
Exactly.
The problem is you're actually ending their pathway before you've ended the episode with them, kind of.
No, but that's not a problem. That's a good thing. So you can end the pathway. You've got to get this questionnaire, the treatment pathway end questionnaire. And then even if you go, okay, complete your questionnaire, I'm going to end that pathway of treatment, get them to complete it in the clinic while they're there with you. You can have a chat with them. Okay, where to from here? Looks like you're moving along pretty well. I'm going to end the episode. And that way you'll capture that outcome. It's done because you've got referral and you've got pathway end questionnaire. So that's your bookends.
I think in our clinic, Janelle, that we do a pain management program, and that's often when we try to do the pathway end.
That's definitely the only time we do it.
Yeah. And then, yeah.
I think
That's when we're trying to introduce the episode end as well, isn't that right?
It automatically happens when we do that, unless they've got a medical appointment or one-on-one therapy coming up, and we wouldn't end the episode, but we would end the treatment pathway. So we'd still
end the treatment pathway. Yep. Get that questionnaire. You
Yep.
can still, enter things into their episode, and then in a week time, maybe end their episode, and you'll still get that outcome because you've got the pathway end questionnaire.
Just about the number 4, the post-episode questionnaire, because we have a review, a 3-month review post-PMP as our sort of way of collecting the post-episode questionnaire, I believe. Is that right? And then I'm just thinking, how do we actually get that data point? Even though, Janelle, you did say that it's sort of, point 3 and point 4, it's question mark whether that actually changes very much, and point 3 is probably the best. But with point 4, how do we actually, operationalize that so it becomes routine for all of the people in our service?
Okay, to get number 4, there's another very important reason why episodes need to end. Because when you click end an episode, and I'm ending this episode now and the treatment's complete, and I go submit, that is then in epicentre, it's time stamped to create the post-episode questionnaire. So it will be generated in here. So, and that's customizable up the top if you've got the sort of admin access to epicentre. You can customize how soon you want that to pop up. So if you want it to pop up in 12 weeks, you can put that in, okay? But you have to use this one that pops up here. It's not good to create one yourself. You know how we went through that process later and call it the post-episode questionnaire? So the only way this little table here will be generated is if you've ended an episode, time-stamped epicentre, and then it will automatically generate in this box all of the questionnaires you have to send. So one, it stops anyone having to worry about, oh my God, who needs to be sent a questionnaire? They're automatically generated in that table. So you don't have to ever worry about who, just keep an eye on this bottom menu and have a look, because this is what tells you, these 3 spaces down the bottom tells you what you need to do. So
Janelle, it is written in chat that we have 344 of those tasks, or 377.
Yep.
Okay. Any like that?
Look, you may want to go through them and delete ones that are really old and just start fresh, because that's a lot. You may want
all of them at once.
You may want to click on them all and send them. You can now print off lists and things. There's lots of more things you can do if you're on version. What version are you on of ePicenter? 2.2.5?
With these ones, the golf.
2.3.0.
Okay, so be good to update onto 2.2.5. It's easy to update, and in fact, there's a lot more benefits to this version. Everyone needs to be on the same version, by the way, if you've got more than one computer.
Everyone stop using.
Yeah, but this is, so Carlos, this is what makes it easy for you guys, because you can manage it this way. So you click on there, you just select the ones you want to send and take action, and they're gone. So you don't have to worry about, oh my God, who's finished an episode? Who needs a post-episode questionnaire? Because they're automatically generated there. So that's hopefully answers that question. We've got heaps more to go, but we're probably running out of time. Shall I keep going?
Just thinking, so Eddie and Sue have to go to an assessment at 1:30. I'm happy to stay on, and we'll continue to record, and
we'll record.
Finish what you wanted to sort of go through, if that's all right, and then everyone will get an access to the link anyway.
And please, Eddie and Sue, email me anytime with weird and wonderful questions because I love them and I'm happy to help.
You're going to regret that.
No, I love it.
Carlos, I forwarded you my RAT tool, and it'd be great if Janelle could have a look at the last page of it, because like the surprising things and the things that don't make sense.
Yeah, cool.
I forwarded it.
I'll start with that, Eddie. All right. So basically, to make it all work, you need strong exec support. That's why it's good that you're here, Birgit, and listening through. You need engaged clinicians, and that starts with like bringing ePPOC into everything you do, like staff meetings, a little 5-minute session. How are we going, you know, in each, to make it embedded. I'm going to embed it into your service delivery with your mapping, which is really important, and also getting help from us, which is what you're doing. The office use only section, your completion rates. So that was number 3 of my list, have gone down from 81% to 41%. And look, that may be related to staff and just having the time. When I say office use only, really it's important patient medication data, and it's important for you guys to print it off in individual reports to have that information there. And it also generates important medication data in your reports. The next section takes you through that. I don't know if you like how to enter it. So if you wanted to go through that, I can. Otherwise, we can skip through to the next section. What do you think, Carlos?
I think it's important to discuss it.
I think the issue for us is what Eddie just put in the chat, and I put it on my RAT tool that you haven't got yet, Janelle. But you know, we've had to transition from paper-based questionnaires, or 85% paper-based, to 85% online, obviously, in the last 12 months. And our follow-through of the office use only section has been really poor, because the questionnaires are being completed online, and then we're not going in, and we're not we didn't realise for a little while, or at least some of us didn't realise. And
I'll
then
show you a
so
simple...
just wondering if there's a system or a way to
there is
more easily.
So if you're looking here at epicentre now, you can see a colour coding system on the side. Can you? Yes.
Yes.
The updated one. In the one that I've currently got, which I'm accessing in the Anglers, we haven't got that.
You should have, if you click on the questionnaires page, the main questionnaires page.
I think it's because I reckon it might be our version that's old. So since our outage, things seem to have reverted to an older version.
No, I'm wrong. I was just on the wrong page.
No, we've always had, there's always been colour coding from the beginning.
I've just never looked at this page.
So this is the main questionnaires page. So I was on the patients page before. This is the main questionnaires page. This holds every questionnaire, not every questionnaire that's ever been generated. So you may or may not know, you can sort all of these bold headings. Plus you can also you can sort through categories up the top through these tabs. But if I click over here on the status, you'll see that it's sorted it in colour code. So green means the office use only section has been completed, dark green. If I scroll down to light green, that's the most simple way to work out which questionnaires need the office use only section completed. So anything that's light green, if I double click on that now and enter the questionnaire, I can go straight to the office use only section and complete it. Woohoo! So all you got to do is look for the light green.
Awesome. Thank you. Didn't even know that existed.
See, there's many things I can teach you to make epicentre. We can do another separate epicentre session.
Is there like an online tutorial that we can?
Yes, I can give you, well, sort of. I can give you documents to take yourself through. But let's just have I probably don't need to tell you about the why with medication, because it's important to understand medication use of our patients. And the questionnaires provide a list of different things you do, but the office use only section just involves you entering 6 variables or 6 elements of data that help you understand the patient better and their medication use. So let's have a look at the 6. These are the 6. They're very simple, yes, no, except for one, which is entering the OMED, and we'll talk about that briefly. Cool. So at the start, again, as I said, anything that's pale green, it needs to have the office use only section completed. So you just double click on the line, it opens the questionnaire, go on in and get started. So, and then as you saw, I clicked on the tab for office use only and it takes you straight there. So what have you got to do? Did the patient give you a list? Well, you can see here, there is a list. So you just go, yes. Well, that's not rocket science either. Step 2, are there possible inaccuracies? Look, we only put that in there because, on example, because these are supposed to be patient reported. So we can enter medications that patients provide to us afterwards. Oh, I forgot to tell you about X, Y, and Z, but they should be patient reported. So, but for example, you might have got a referral letter from a GP with 27 medications on it, and the patient might have said, oh, I take Panadol. So you might want to put that in. To me, this is a sign that you want to follow it up. So if you say yes, there's possible inaccuracies, it means someone in the team needs to follow it up with the patient. But most of the time that will be no. Step 3 is about the drug groups. Now I've created a tool that helps you work out what drug belongs to what group. And these are drug groups of interest in pain management. So you might check, you can see this guy's having an opioid, they're having an antidepressant, etc. Yeah, go.
Oh, sorry. No, we'll say goodbye to Eddie because Eddie's going to start her assessment.
Oh, yep, no worries.
But you were saying that you provided you've got a particular guide to the drug group.
Yeah, these are all available on the ePPOC website. You just probably haven't looked or don't know, so I can send them through to you and send the link as well, so you can look at them. So that's about just checking a box. Step 4 is where you get to open. So the conversion tool to calculate an opioid is embedded in ePicentre now.
Which is really good.
Yes, it's amazing. Yep. So you just click on that to go to the conversion tool. This is where you only enter any opioids a patient's taken. So there's the conversion. I won't spend a lot of time, but because this is a whole nother session I can do with you. If you want to go through it in detail, I'm more than happy. But
that would be great, Janelle. It would be great.
Yeah, I can do a whole session on just straight out epicentre. But at the end of the day, the beautiful thing is at the bottom of there, it says, do you want to paste the OMED value into epicentre? And you're like, hell yeah. So it just pastes it straight in there, which is amazing. Step 5 is like, are they on opioids more than 2 days a week? That's yes or no. Step 6 is like, are they on an opioid replacement program? That's if they're having, methadone, or they're on a program where they're trying to reduce opioid medication safely. Simple yes, no. And then is it complete? Woohoo, it's complete. So that's your office use only, which will then, as I've mentioned, change it from light green to dark green in epicentre, like I showed you back there on that screen.
Is there a reason why that data doesn't go straight from, as the patient's doing it, that doesn't go straight into, like, because we do, like, again, 85% is like online. Why that data has to be processed by the team before it?
Because it's very hard because patients will spell things wrong. Can you imagine how to write the software for a program to pick up endone, for example, spelt with a capital, with a small letter, spelt wrong 500 times. So it's just too complex and for the software to be created. So there are only 6 small variables. They're all easy except one, which is the OMED. And really you get savvy with the OMED very quickly if you're doing it a lot. And I'm seeing nods from Alison, which is great. So if I'm going to number 4, we've talked briefly already about ending episodes. It's important that you discuss it as a team. At ePPOC, when we had a lot of patients, like when they first come in with chronic pain, people are saying, well, they've got chronic pain forever and it doesn't go away. But actually, the whole idea of treatment for chronic pain is to teach people to self-manage. and push them out of the nest. So we developed these phrases with the Clinical Management Advisory Committee about, okay, for example, an episode, you might end an episode when active treatment is completed. That means if you're just got someone on for ongoing review, you're not actively involving them in a treatment program. So it's not active treatment. If you, for example, begin to taper someone's appointments, that might be when you say, okay, our episode's ending. Or as I said, ongoing review. But this conversation enables, one, for you to embed that, getting that pathway end questionnaire on or near the final appointment, so you actually get the results by getting them to do it in clinic. And two, ending the episode does two things. It gives you that episode outcome, and it also timestamps epicentre for the post-episode outcome, as I mentioned earlier. Number 5 was talking about reducing unnecessary questionnaires. Patients just, they get over it, as you are well aware. So it's just a reminder that if you're clicking on adding a questionnaire yourself, really think about, is this going to add clinical value to my patient care? If it's just like, oh, I haven't seen her for a while, I'll see how she's doing. Why not have a conversation with your patient first and see if they are doing more poorly? Then you might want to get a clinical snapshot. Otherwise, stick to the automatically generated questionnaires in epicentre. Does that sit well?
So Janelle, we did 119 ad hoc ones last year. Is that what you had on that previous one, 119 ad hoc?
Oh, yes. I just forgot to mention that part. I was busy focusing on the passed out dog. Yes. So, for example, we try and keep services to have less than 10 ad hoc questionnaires. Of course, if they're an important part of your care, I'm not saying don't do them. Absolutely use them if you need a clinical snapshot of a patient in time. But 119 is a big number, and you only had a response rate of 50% anyway. So
it's probably used because of that. We're a little bit unclear about what that end of pathway questionnaire can do for us and help us with to determine whether we've actually finished or not. Because that, for me, in my head, it actually is helpful to know it. You are almost doing that questionnaire before you have decided to finish the pathway.
Yeah.
Because, and it's not the way it's read, which makes it confusing probably. And if we decide what the business rules around it will be, we will be.
Yeah, it's as simple as doing that, deciding the business rules around them. Yep, Alison.
With regards to those ad hoc questionnaires, I'm wondering, so we create questionnaires at the beginning of our group program and at the end of our group program. Do they get counted as ad hoc, or do they get counted as something different?
Okay, if you've generated them in, wait a minute. If you've generated them in epicentre, for example, now who did I started someone on a concurrent pathway. Oh, here, this person. When you start someone on a concurrent pathway, you'll see that blue things mean that they're active buttons. So I'll have to start this person on just very quickly. That. Okay, yes. I'll do it really quick, sorry. Okay, I'm going to start them in a pathway now. So that's today. I'm going to start them, you use concurrent pathways. So I'm going to go submit. That'll generate a questionnaire because it's a pathway start, but I'm going to say, you know what, never create because I just got a referral. So you'll see now I've got a blue lit up start group button. So let's say Bob comes in a week later after referral as well to start the group. You must start the group here. And then again, I'm going to put today, go submit. It'll generate a questionnaire. But again, because the referral questionnaire was only 2 weeks ago, I'm just using an example, I can still go never create because then it will use, it's still a questionnaire, but it will use the results from the referral as the results for that one. So you need to end the group. Now this is the one where you might want to get a questionnaire. So it's coming up to the end of the group. So I'll have to put in a different date probably. And then this is the one I want to create now, because this is the important bookend. So this might be 6 weeks later. So I'm going to get this one because I really want to find out how they did after the group. Now, if the pathway is going to end in the next week, you'll still need to click on this, put the date, and if it's the episode end, click submit. It's going to tell me, I just didn't do that, sorry. Right. It'll generate a questionnaire, even though he might have only had a week, like one appointment after that. If he's had lots of appointments and it's been a long period of time, you should get this questionnaire. If it's really close, again, you won't need it because you've got the result of the group program. So it's all about trying to reduce unnecessary questionnaires. And I can talk at length about this a little bit later if you want to go through the possibilities. But I have an example coming up.
That was a great answer. And so it basically says that ePPOC is using any questionnaire that's been previously collected as a proxy kind of thing. But I still wasn't sure. I'm trying to figure out why we have 119 ad hoc questionnaires, to be quite frank. I don't know
when I look at
how we're generating them and why and when. And I just wondered so we generally do collect a group start and a group end, whether they are, because generally our group is starting much more than 3 months or 6 months since the last questionnaire. And so we definitely collect that. And so is that recorded as an ad hoc, and is that why we've got 119 of them? I'm wondering.
So ad hocs can only be recorded if you, for a patient, for example, you're here and you're like, okay, if you go to questionnaires for them and you've clicked add. So at all times, you really should avoid doing that and use the questionnaires that pop up in ePicentre by clicking on one of the blue buttons back, on a patient page. So questionnaires will automatically pop up. If you are deliberately going to a patient's page, looking at their questionnaires and clicking add a questionnaire, that's you doing the adding and not ePicentre. So that's potentially
that's a total
missed opportunity. So this will help.
If I can ask a question. So what we have is, we have them go through SOS, medical, and then allied health assessment, 101s, and then we, they're on the wait list for PMP, and the PMP is where we start, and we get them to do a starting ePOC and then a finishing ePOC, that sort of stuff. I feel like maybe what we're doing is that we're not ending their pathway that they've started, from SOS to 101s, and then we're not creating a new pathway for PMP. Is that what we should do?
Look, I can see a lot of gaps. So already by listening to you. So when a patient starts, so they come in, so this person's is a new referral. So you start that obviously, and okay. I'm going to get a questionnaire for that. So I'll go create now because that's the referral. So that's when they first come. So what happens next?
They go into SOS, for example, or a medical.
So what happens? Is that a first clinical contact with a clinician? Yep. Okay, that's when an episode should start. So but they're going into SOS now. So we'll start the episode. That absolutely, whatever that is, an MDT assessment or a single clinician.
We do that as the education orientation program.
Perfect. Yep. So then we go click. So that's wait time from referral to episode start. Right. Now you leave them in. All the things are now going to occur within the episode. So all service events. So let's say they start seeing someone what happens next? So they've done SOS. What next?
Medical appointment.
Okay. So this is when it's important. And this is one thing that in your report, you guys have, not been able to do is enter service events. So that's when you can add service events over here. And they're things that are occurring within the episode of care. So then let's say you work out, okay, they've had medical appointments and done all that, and now you've decided what pathway to start them in. They must be started in a pathway as soon as you know what treatment, whether it's going to be individual appointments or, you know, a pain management program or a concurrent, you must start them in one of the 4 pathways. And that's...
I think, Janelle, what Paul has said to me is that, you know, that sort of, adding the different kind of service events, that sort of stuff is probably too hard for our service. And what we had agreed upon was that we would sort of do something like a concurrent pathway, group individual. So so when the person starts, we start their treatment pathway, I think.
Yeah.
Am I off the mark, Ali?
No, it's a mixed bag. So sometimes if someone comes to SOS first, we put it down as the education orientation program as their episode start date action. And then when the pathway started, then it's always a concurrent pathway. That was the decision we made, a business rule decision that we made years ago, because we felt like, because people flex between different types of services within our clinic, they might have some individuals, then they might do some group work, then they might go back to individuals, that we didn't feel like we had the capability to be constantly updating epicentre to reflect that. So we just stuck with one. And we knew that would limit our ability to identify and differentiate between different things. But we sort of felt like, you know, that was as good as we could manage with our clinician time. And, you know, we have no admin support for this. So it's sort of like, that's the best of our lot kind of thing. That's what we decided.
And this is why it's important to know the context, because you've rightly identified the problem with concurrent pathways, is that it's impossible to tell which part worked. Like, did the group how's our group program going? Oh, we actually don't know, because it's mixed in with the individual in the report. So you can never really identify.
Well, we felt like we could. Like, we felt like because we were making a real effort to get group start and group end questionnaire results, we felt like because of the mapping in the report, that we could still see improvements or changes that happen within that period. So we could differentiate if we were able, you know, with that lens. But when you generate data and reports and things and analysis from epicentre, there is no differentiation.
So if they enter a group program, they're not doing individual appointments at the same time?
Not generally. I mean, they might have a medical appointment during that period, but generally speaking, I mean, they do have some individual appointments as part of the group, but we like you know, we don't actually record the service events, so it sort of hasn't, and it's usually as part of the group program package, shall we say.
And look, and I know Vigit was sort of saying last week, how can we use the reports to sort of advocate up for staff or facilities or equipment or etc. And unfortunately it's the service events that really bulk up the report in that aspect. So I've got tips, I've got efficiency tips, if you'll bear with me. So let's move forward, because I see where you're going now and I understand what you're doing, but it might be better to think about consecutive pathways, and honestly they don't involve more questionnaires or more work. So I'm all about reducing the burden to patients and clinicians. So here we are. Number one, this is number 6 in that list of 8 things that I wanted to help you do, and one of them is setting up early expectations with patients. And you may already do this, but one of the great success tools has come from Barbara Walker, and they have developed an introduction letter which really builds with patients an understanding of what the questionnaires are, when they're going to be asked, and how they're used, so that the patients really see their value. Because as we all know, adults want to know what's in it for me. That's a standard thing that all adults do when it comes to learning. And so one of the things, this is just a little snapshot of the letter, which, you know, you put your logo at the top and you say to the patients right at the start, you know, we're going to ask you a lot of questions. So what's in it for you? And I don't expect you to read that, but it sets up expectations of when they're going to be asked, and what they're going to be asked, but what they're going to get out of it. And so that, I know, and I've done it with all of New Zealand, has increased outcome numbers exponentially because patients are in it. Like they feel part of their care. So that's one thing we can do. I'd love to see, I know it's hard, but there are ways to make entering service events really easy. And one of the biggest things I've done with my services in New Zealand, and they've been using their reports to get more psychologists, iPads, tablets, and all that sort of stuff. But you can see the benefits there. It really allows you to demonstrate, and it allows you to talk up with your report to executive levels to advocate for more staff, equipment and facilities. And one of the ways, I love this slide, it's better to work in bulk. So the ways that I get services to get their service events in is just entering them in a bunch in bulk at the end of a pathway. So if you, for example, if you thought about it, like they don't have to be super exact to the minute, but if you thought about it and you know through care, the average group runs for 24 hours, they might see, you know, can you see I've just added them all up in bulk, and you might just throw them in at bulk at the end of the pathway in one go. It just doesn't make sense to enter them as they happen because it's diabolical and it's just too much. But if you have a think about it as a team, about the average care that a person receives, what I've done with certain services is created this little, you know, you ever been to a doctor and they pass a slip to their admin and it tells them what schedule you're on and how many hundreds of dollars you're about to be charged because you've been to see a specialist? This is a similar thing. If you wanted to, some services have introduced this to help if indeed you have admin staff, this is a luxury. So you whack a patient sticker on and you put the total hours. But the more user-friendly one is having a discussion at a team what an average episode of care would have within it as far as services events go, and enter them in bulk at the end. And of course, obviously, if it's grossly different, you can highlight that or enter that yourself. So that's the service events. You've already mentioned, Alison, you've highlighted something really important about concurrent pathways, is that it is difficult to work out why the grass is greener on this side of the fence than the other. And one of the things I suggest services do, if, for example, you are doing what you do and you have a group program and then you might have a bunch of individual appointments after that, is to separate the pathways and then use the service events as an example of what you're doing within them. And these things get very complex to look at, but bear with me. So to get the most out of your pathways, and what I mean is the data, and to find out which is doing the best for what, it's really better. In fact, no one really wanted concurrent pathways, and there's very few services that actually use them. So using single or subsequent pathways is always better from a data perspective to understand what's doing better for your patients. So you could still do the same thing and it would not involve more work for you clinicians or more work for the patient, because there's no extra questionnaires because of that proxy value that we get from recent questionnaires. So even if you had your group pathway, for example, followed by some individual appointments or vice versa, whatever, no extra questionnaires are required because you still get the referral. You start your first pathway, which might be a group. You don't need the pathway start questionnaire because it's close to referral, but you do need a pathway end. So you'll get your group outcome. Then you'll understand wholeheartedly what it is. You can immediately start your second pathway as soon as they finish group, start them in a new pathway of individual appointments. You don't need that questionnaire. Why? Because the previous one will be proxy. And then once they've finished a bunch of individual appointments and you grab them and you get that okay, we're tapering, we're getting close to the end of an episode. Let's get a pathway end questionnaire. And that then will become the episode outcome. So you've still got 1, 2, 3, 4. The post episode is afterwards. Yep.
Okay, that's good. I like that. I have a question though. So, and I think this will be easier for you to answer once you see our map. But I'll just run you through an example of a typical journey. So someone comes to the group orientation session, which is classed as the orientation, not treatment.
Yep.
Okay, and then they have their first, their next appointment, which is a treatment appointment. So let's just say it's a group education session again, but it's classed as treatment. So we start their first pathway on that date when they come, and that would be, for our reference, it's called allied health training. And then 2 weeks later, they have their first medical one-on-one individual appointment. So, but they're still going to be waiting another 8 months before they start more group therapies, because group therapies come at different intervals depending on wait times and so forth. So it might be their first pathway got started when allied health training happened now, but it's 8 months before their next group intervention. But in between, they'll be having some other individual interventions in the way of assessments and treatment. So is that where the service events play into it and they get allocated to the pathways, or does it not matter?
Yeah, if you enter a service event in epicentre, it will all automatically be attached to whatever the current open pathway is. So it will be automatically attached. You won't have to do anything. For example, so I'll start this person in a pathway. Let's start them in an individual appointments pathway. Of course, I don't need that. I'm going to say never create because I just got their referral questionnaire. So now anytime I go to add a service event, you can see, if you can see this, I'm currently in pathway 2A, and service events will automatically be tagged to the open pathway. So you can drop down and say, oh no, they're not within a pathway. You can say, oh, I forgot to add a service event to appointment 1, but you don't want to be doing that. That's a lot of work. So for your reference, they're automatically linked to the most current open pathway. But if that was the case, then I'd probably think about entering them into individual appointments and then let them go through their individual appointments, whatever happens. And then at the end of that pathway, you might go, that's when you might enter in all your bulk. Oh, they had 4 hours of physios, 2 hours of psych, 1 of medical, etc. Whack them all in, end that pathway. And then when they're coming for the group, leave them in the episode because they're still within their episode of care. So I would end that pathway with whatever date it is. It's not the end of the episode. So just go submit. It'll generate a questionnaire. Do you want to find out how they're doing after 6 months of individual appointments? You probably do, because it's been 6 months since the last questionnaire. So get that questionnaire and then start them immediately in a group. Just today, select group, go start. You're not going to get a questionnaire now because you just got one. So now they're waiting for their group program to start. And then you'll get the next one at the end of that. And then the important thing for groups, so you can measure outcomes by intensity, is to add, when you're adding a service event, to go pain management program group. And then obviously here's where it's really important to put the bulk hours of your group, because we also measure outcomes by intensity of group programs. So whatever the maximum outcome hours of your group is, it's going to tell me that's invalid because I haven't entered a date, but that's fine. Okay. And then that's entered.
So, you can't have 2 pathways open at the same time.
No.
Yeah. Okay.
So you either use service events to demonstrate what you're doing within it, or
Can you look backdate? So because our Sorry, I didn't mean to talk over you, Janelle.
No, no, you're right.
I'm just thinking about our service delivery and our map. And because that very first group education or treatment session is often well before the full group program, could we backdate that group pathway start date? So for example, they do their initial group treatment session today, and then they start their proper 8-week group program in September. And when we're about to register them and get them into that group program in September, we say that we can backdate the start date of their group pathway start until today, or would that just be false and not really, would that backfire?
You know what, I'd probably call that, I wouldn't call that first group, it's not a group pain management program, is it? It's just a group session. I mean, I'd be more inclined to call that, you know, education program, rather than, it's not really a group pain management program where there's a series.
No, you're right. And so then would you still list that in a pathway of individual appointments and list it as an education of service event, or which pathway would it fall under?
You know what, if they do that before, it might not even be in a pathway. It might just be some service events before you commence them in a pathway. It might just be that you go, you know what, everyone has a 1-hour group education. How long does it go for? 2 hours? 2 hours. Right. I would not even call that a group program. Or pathway. I would call that maybe.
It is actually put in there so they get more education about what pain pathways there are really, and whether they want to engage or not, whether they think this one is for them. So in terms of that, we need to have a purpose to have to SOS, and I think we do have that, but we won't have different outcomes from the beginning. It's only a 2-hour program.
No, I wasn't talking about SOS, Birgitta. I was talking about the next one, which is allied health training, which is much more treatment based, you know, like it's all strategy based training, and it's the first beginning. But I hear what Janelle's saying about, but there is an option to select pathways and determine further engagement with allied health at that point. So yeah, it's a bit of that. So I think we can call it that. Yeah, I understand now. Thanks.
These are all things that you'll go away and you'll think through more as you're looking at stuff, and then we'll chat a bit more. Look, the other slides, just the last few, if you can bear with me, these demonstrate, and you can look at these at your own pace as well if you want to. But this is, for example, having consecutive pathways rather than concurrent. And these are just ways that show you still that you get score the 4, but it shows you questionnaires you don't need to get to save you time and the patient time. And the other way is for single pathway questionnaires, and it shows you again score the 4. So I think it's probably better if you just sit down and look at, because you know in depth how your service works and how it runs, how things might fit. And then that way, when I have a look at your map and I try and embed it, it'll make a lot more sense, I think. But I'm just asking you to maybe, you can keep going with the status quo. It's no skin off my nose. I'm just asking you to consider these things as options. That's all.
Yeah, I reckon if you're willing, that is, what would be really fantastic is that we send you the process map that we have of our service, so you can kind of know like what we sort of provide and how that goes, and then hopefully we can sort of meet again and sort of talk through that, so then we can kind of get your recommendations on how we implement implement.
Have you also sent kind of a dot point of like Bob comes in, SOS, and that would be really helpful too as I'm going through it.
Yeah, we can definitely do that, and we can present it to you. Whether we do that like offline, present it to you by like a PowerPoint presentation or like a process map, and then we can get back together with your recommendations or
well, it'd be good for you to think through actually, and you start thinking about, now that you understand, you start thinking about where these embedded moments are for ePOC, and then have a go and see if you can embed them. And then I will send it to me, and we can work together. I think it'll be really exciting. But I mean,
I think for the pathway starting, at SOS and at the initial medical, we can definitely get that better. There's such easy ways. Like, for example, we can actually, do that at case conference. We can do it while, SOS is starting and the patients have started. We can actually start those pathways.
I can already see the wheels turning in everyone's head, thinking about ways that you can do it. So look, just to wrap up for me, I've gone way over time, but so these in front of you now are the 8, from reviewing your report, these are the 8 key things I'd either, some of them you need to do, and some of them are for your consideration, given, because remember, my perspective is very different from yours. But from reviewing your report, these are the places I would start if you want to get the most out of your reports for both your patients, yourself, and your clinic. So these are what I'd start with. That's the end. Thank you so much for your time. But it's not the end. It's the end of this discussion, but it's not the end of us working together. And I really look forward to getting ePOC embedded and making things more efficient for you guys, so there's less work. That's what I'm about. I want to ease your burden and the patient's burden. So that's part of my role. So if I can help in any way, and stay in touch, and if I would love to see you guys have a go at embedding the 4 moments into what you do, and considering those 8 points that I raised about, and if you grab hold of them and start working with them, you will start seeing outcomes climb, and you'll get results in your report that are really useful for you and the patients.
And Janelle, you'd be okay with us concentrating on the first 3 moments at the moment?
Oh, yes.
If
we need to concentrate on aim for equal, score 4. Yep. And get ePOC embedded. The rest will start coming after that. But if I was to focus on 3, it would be the top 3.
And from my point of view, in terms of your service events, are you talking hours of contact per discipline and per episode, or per pathway, if you like?
Yeah, so
what's the service
events,
what you're talking?
Up here there's a great big list, but it's individual contact with patients, it's multidisciplinary team assessments, it's if you had a telephone.
For example, a client comes in and see 3 or 4 different clinicians. Is that one service event, or is it 4? Like 4 clinicians in one?
So that can be an individual appointment with 1 or more clinicians. So there's so
it's really the Department of Health and Human Services definitions of service events then that we're talking about.
Fairly. I mean, we didn't just make them up. The CMAC, our advisory committee, told us what service events to put in there.
And from probably next year, so at the moment we're doing target contacts. I'm just trying to find an easy way to determine what, because we do have HMS that actually gives you target contacts rather than service events these days. But from next year with activity-based funding, it's service events again. So I'm just trying to find a quick, easy way if we needed admin to put that in, because that's cumbersome otherwise. Or we just make up what's an average for PMP. Is probably not hard. It's kind of, if they turn up for the 8 weeks, we know what they will be getting.
Exactly. And look, if it's a pain management program, you don't even have to enter in what they had. You can just enter group and enter the maximum. The important thing is the maximum hours, which might be 36 or 24, and that's a one-off. But if, of course, you wanted to get more involved, you can sort of say different things that have happened to the patient, but to try and make it efficient, you're still measuring outcomes via intensity of group programs.
Right. Okay. But also, and the other thing I think it would be important to do, how many medical appointments did they have during that episode?
And absolutely, that can be entered. You can put the pain management program in, but then you might, that's my dog. You might choose to do the bulk entering of service events at the end of, and then that gathers in all those different clinicians that are involved in care.
Okay.
Thank you so much for your time and putting up with me for so long.
You've been incredible, Janelle. I feel like I've had about 6 light bulbs go off in my head, and I've got a few more turned on with ideas and stuff, and it's really cool to think that we can turn it around. And it's a bit disappointing that we're looking a bit crap, but I think we can get better.
Nah, it's just, I just call it a PB. It can only go up from here. So, unfortunately, it's you guys that have got to do, I get to just sit here and say, you need to do this, but it's you guys that have got to do the hard work. But I like to work with you, and it takes generally a couple of reports to start seeing the difference. So, bear with it and don't get disheartened, because we could see really cool things happening even by your annual report for 2021.
It's kind of like Kozios go to Everest, I think is our climb. Yeah.
It is, but it's exciting and we're doing it together. So hopefully I can keep you, I think, you started and then you were just left to just, float around and have a go and do your best. And now that you've got someone to guide you, I can be your guide. I'm your Sherpa.
You're our Sherpa, yeah. No politics, please.
Dear. Anyway.
Yeah, thank you so much, Janelle. I'm sure we'll talk again.